Good morning, everybody. Distinguished dignitaries and all the registered participants. I would first like to thank all the management of ALSHIFA Hospital to give me opportunity on this August conclave of patient safety. So today we'll directly come on to the topic. My role is to ensure the key insights of patient safety in laboratory medicine. Upgradation of NABL Standard 2022 is launched in December 2022, and after December 2024, every lab has to adopt that standard. So this is the incubation period given to all the labs who are following NABL current standard 15189 2012 version. So I'll be taking care of that portion in between this patient safety goal topic only. So we'll start in hospital patient safety goals, international patient safety goals, you know. But my role here is to take care of the patient safety in laboratory medicine. So as you all know, it is a top priority of a laboratory medicine department to give the accurate and reliable result. And in current era, you know that the 75 to 80% of clinical diagnosis and management comes through our laboratory medicine department, different tools and different test diagnosis. So in laboratory medicine, the whole testing process is a complex process. It involves the equipment, it involves the reagents, it involves the technology and interpretation of result. It's a complex process. Now, so this is the brain loop in laboratory medicine. So whenever the patient comes to your OPD for a consultation, he gives his symptoms, he gives some signs, and then you elicit the history and you examine the patient, and then the clinicians have some clinical suspicion of different diagnostic lesion in his mind. So it starts from there. So our patient safety, it starts from there only, not only when we receive the sample in the lab. So why? Because physician, once he starts suspecting disease, the first thing, the laboratory medicine is divided into three parts. You all know, pre-analytical, analytical and post-analytical. So in that loop, so first in the outside of the laboratory, till you receive the sample in the lab, patient identification. That is the most important portion in the patient safety in laboratory medicine. Correct patient identification is the most important factor in patient safety goal, particularly in laboratory medicine. How will you ensure it? At least two indicators. We always emphasize at least two indicators of patient identification will be there. You have your own hospital ID, OPD ID, indoor ID, then there will be a MRD, a unique patient consultation ID. And then comes the laboratory unique ID, which is specific to that patient throughout his course of the stay in the hospital. So patient in the lab is identified by that lab unique ID. So whatever the test has been prescribed in different section of the lab, whether it is hematology, clinical pathology, microbiology, biochemistry, histopathology or cytology, patient will be traced by that unique lab ID, which is must and is as per standard. And it should be traceable to your unique MRD number. So on a successive visit of the same patient to that hospital, you can easily trace the previous laboratory reports of that particular patient. That is why it is important that patient has to carry their own lab unique ID. Okay, so because why it is important? A patient of a thyroid malignancy, after 4 or 5 years, when he visit with some recurrence of cervical lymph node or some other metastatic lesion anywhere in the body, when he visits successive visit, he should be traceable with his whole clinical data in the hospital with that unique MRD number with traceable lab unique ID. So that is most important. Then specimen collection. We'll take this one by one in whole my session. What are the importance of each and every this factor in the all three phases. As I told you, patient safety indicators in laboratory medicine are divided in 3 phases. So in pre-analytical, most important, and I tell you that 70 to 85% lab error occurs in pre-analytical phase, even in the ultra modern latest equipped laboratory of the world. And it is not about India, I am talking about the global statistics. So pre-analytical phase, which is ignored mostly in many setup, when we assess the different labs across the country for different assessment, we know that the whole lab is mostly focused on their ultra modern lab equipment, methodology, QA, QC, well qualified technical and doctor staff, but they forgot to take the importance of, understand the importance of the most critical phase of the laboratory medicine, that is the pre-analytical, and it's a global data that 70 to 85% lab error occur in the pre-analytical phase only. So if you receive a sample which is a compromised integrity in your lab, even if you have a latest ultra modern equipment, you cannot give the accurate and reliable result which can give the proper treatment to that patient. So that is why in patient safety, particularly in laboratory medicine, pre-analytical phase is the most important key factor. So how will you ensure your pre-analytical phase is reliable or accurate when you receive the sample in your lab? So by correct patient identification, as I told you, phlebotomy associated negative events. So your phlebotomist is the first person who interact with the patient in any setup. He is the mirror of your lab quality. A semi-skilled staff who understands the intricacy of report when he receives the request. So he needs to be trained properly that what is the amount of the sample to be collected, what is the container is required to be collected, what is the time to be required for this patient to collect the sample for that particular test, what should be the transport time for this sample to reach to the lab. So all those key area in pre-analytical phase, the important key person is phlebotomist, which is not given that importance in laboratory medicine, but they are the very important stuff in our whole laboratory medicine. So phlebotomy, how the sample is collected, smooth, even flow, is there any negative suction, too much, proper vein identification. So these are key areas. Then specific specimen identification. If there are multiple battery of tests is requested, he should understand which sample to be collected first, order of draw, culture, coagulation. So he should understand. So there will be small things which very important, play a very important key role in your correct sample collection. So specimen identification. Once you receive the sample in the lab, there are more than around sometimes 200, 300 samples, and samples are collected in a ground floor in a OPD area, and it is transported to the laboratory medicine department or on a 4th or 5th or 7th or 8th floor. When you receive the sample, the specimen identification is very important. Your identifiers, proper labeling with traceable unique lab ID and MRD. Order entry. How will you enter your all requested investigation in your software? Are you understand what is written by the clinician in the request form? I'll give you a very simple example. One clinician has written HB and then electro. Last 3 words are not readable. So one staff in the lab who enter HB electrophoresis and the other staff enter, I give the same request to the other guy in the assessment and he enter HB and electrolyte. Now you see the difference of these two tests. One test takes almost 5 to 6 hour turnaround time. One test is HB and electrolyte. Very important, electrolytes needs to be immediately informed once ready. Potassium. Maybe there will be some dialysis is going on of that patient. So order entry. So the request form, your journey of quality or patient safety starts when you start reading your request form. So clear, understandable request with proper age, name, then clinical history. Why clinical history is important? A patient who is on oral anticoagulant, drug history is very vital. Your INR report, biological reference is variable. It is different for a normal healthy individual and it is different for those who are on oral anticoagulant. So this is the very important part, and it starts from pre-analytical. Before you collect the sample, you start getting your request and collection of sample. So all those activities before you analyze actually your blood sample in the lab. Specimen integrity. As I told you, compromised sample give you a compromised result. If your sample is hemolyzed, if your sample is lipemic, if your sample is icteric, it gives you lot of erroneous results. So sample integrity, not only quality of the sample, the quantity of sample. Every technical staff in the lab knows that what is the importance of the quality of the quantity of the sample. But the staff who is there in the collection area, he should be trained enough that he should understand that a citrate vacuole has a mark, EDTA vacuole has a mark over there. Either overfilled or underfilled sample. Why there is a mark? There is a mark because there is an anticoagulant inside the tube which is proportional to the amount of the sample you collect in that container. So if you collect a suboptimal sample or an overfilled sample, it will alter the ratio of blood to anticoagulant and it will give a impact on your result, quality of result. So this is how such a small steps we can ensure patient safety, because all these results ultimately reflected in terms of your clinical decision and the management of the patient. Effective use of clinical laboratory. So you need to understand that your lab is doing if a GFR, specific procalcitonin, like certain parameters which are very important in critical care of the patient. So your clinician should be provided all the scope of the laboratory and with biological reference and indication, then interpretation, everything. So they should aware that we are avail that facility, we have that facility. So you can decide with this battery of investigation a better clinical management of your patient. Then comes the analytical portion. Once you collect a proper quantity and quality sample in your lab, then it is your duty towards the patient and patient safety that you have to give a correct result by a correct analytical process. So, and verification of any single abnormal result. If your testing process give a result which is beyond the biological reference value, then you should confirm or verify it before it should be conveyed to your consultant or a clinician. Post-analytical communication of test result, very important part. If you generate a very quality competent result, that's not over. You should take care that how it should be communicated. So your report format should have a proper content and report attributes in terms of units, in terms of interpretation of the result. See, if a patient has been blood transfused, 3 units has been already transfused, and then you do a HB electrophoresis, it is of no use. If a patient is having a severe iron deficiency anemia and you do HB electrophoresis, it's of no use. So whatever the result you gain from your well-equipped laboratory setup, G6PD deficiency, in all histopathology and I am in charge of cytopathology laboratory in my institute. So we do daily lot of FNSE procedures, thyroid FNSE, cervical lymph. But unless you give a proper interpretation of the result, not only description, you need to, why Bethesda system of thyroid classification is evolved in 2014. It's because previous systems of reporting thyroid FNSE is not actually getting clinician idea about what to do. See, it is a Hurthal cell variant or a follicular variant. It doesn't make any difference to the treatment to the patient. What makes the difference to the patient? Either he should include chemotherapy, he should include radiotherapy, he should do only surgical removal, or he should just give a conservative line of antithyroid drugs. So that is the crux where your interpretation in the result matters the most. Clinician need to understand that this classification is evolved and now we are practicing that because it has a clinical value. If I report something, some variant of some papillary carcinoma, it has to have a value because it has a different surgical modality or a different treatment modality in terms of patient care. So your patient safety not only overs where you just give you a competent result. It should have a proper clinical interpretation and it should have a proper comments wherever required, advice. So I found many a times who are from laboratory medicine department here in the crowd. Pathologist, microbiologist, biochemist or lab technical people. I found across India that lab medicine doctors are very hesitant to write the advice or comment in the report. They thought that our clinician will not happy with that. They thought that they will not, they will overcome something which is not in their subject. It's not like that. See, 80%, in my first slide I only told you 70 to 80% of your clinical diagnosis comes through laboratory medicine. So it is your duty to guide your clinician at times where they need it. And we know which is the gray area where they are, obviously it's a vast subject. If you take a surgical oncology, it's a very vast subject, very dynamic subject coming up with lot of recent classification. So whenever you write your histopathology or a cytology report or even a hematology report or a bone marrow report, it should have a clinical interpretation, proper diagnosis, your description, and then comes a specific comment where it is needed, like for a prognostic part. When you do a flow cytometry or a bone marrow, it is your duty to write a certain mutation study to be advised to confirm the diagnosis and to take the lead in the treatment part by the clinician using that clinical data what you are providing in your report. So outcome of laboratory is also very important part, that where whatever you serve to your patient, to your stakeholders in terms of doctors, in terms of patient, in terms of third party in terms like nowadays Mediclaim and everything. So outcome of the laboratory, whatever the number of tests advised in a routine practice needs to be analyzed in terms of outcome. Are the investigation are over prescribed or under prescribed? Certain investigations you need to correlate clinically your study, your clinical judgment in the request and the outcome of the result. So that will be the effective use of your laboratory data. Ultimately it involves lot of cost, lot of energy, lot of time. So these are the key patient safety indicators. Pre-analytical, as I have already covered, 70 to 85% of laboratory errors. Then, as I told you, in current era, most of the laboratory medicine departments are very well equipped with ultra-modern equipments. They have a state-of-art equipments and processes, reagent materials. So now in patient safety, considering the patient safety, pre and post analytical portion are still a challenge for patient safety. Analysis part has been taken care by most of the setups where we see the very high ultra modern equipments, but the pre and post analytical phase and pre analytical particularly, most of the errors 70 to 80%. Now patient safety indicators, as I already told you, in pre analytical phase, patient identification. So at least 2 denominators, then proper sample collection, as I told you, regarding the ensuring the proper volume and the quality both. Then specimen labeling, then specimen handling and transportation. That is also very important. So you have a ground floor collection, sample collection room in OPD area, and your lab is at 7th floor or a 6th floor or a 4th floor, and everybody in this crowd knows that nobody transport the sample each and every patient. There will be a cyclic manner every 45 minutes or every 1 hour or every 30 sample or every 10 sample you are transporting your sample from sample collection area to the lab. So how will you transport those samples? What should be taken care while transporting sample? And if there is a holiday or if there is a light OPD or a less sample in the room, and it has to be there in the room for a longer period, sample collection area, then what to be taken care? So that is very important. You need to have at least a basic refrigeration, 2 to 4 degrees. Certain clinical samples need not to be put at room temperature. You need, if there is a prolonged stay in the sample collection area, it should be properly taken care. Now pre-collection activity. As I told you, now you will see the pre-analytical, the major portion in little detail, where we are have to give more focus to ensure our patient safety. Patient safety in pre-analytical phase is the most important because most errors are generated there only. So preparation of the patient. So what you mean by preparation? Like for a lipid profile, at least 8 to 10 hour fasting is required. So your phlebotomy staff, your the key person who are collecting sample, they should understand about the same type and amount of the primary sample. So which container to be taken, what amount of the sample, then special timing of the collection. Like cortisol, you need to collect at 8 AM and 4 PM only. You cannot collect the sample of cortisol at 12 PM in the afternoon. It will give erroneous result. GTT, what are the number of samples collected, when to collect, 24-hour urinary VMA level, how to instruct the patient for the sample collection. So these are all pre-collection activity. Then sample labeling, unequivocal for the identification. Said I have told you that your lab unique ID should be traceable to your MRD number and multiple visit of the hospital of that patient All the previous clinical reports, laboratory reports, all the radiological reports should be traceable. That is the requirement of this standard, and you should ensure it before the collection only. Once the sample collection is done with the different unique ID, it will be a mess. Now your staff should understand that what are the different criterias for sample collection, acceptance and rejection. Okay, so acceptance and rejection criteria should be, if there is a sample collection center in a different part of the city where from the samples are collected and received in the sample collection area, and then it is transported to the lab for a analysis purpose. So whatever the person who is receiving, whoever the person who is receiving the sample in the sample receiving area, he should have a clear-cut knowledge about the acceptance and rejection criteria. Then comes the collection. Your staff is now perfectly trained about the pre-collection activity, every instruction, patient is in fasting, he is in resting condition, he has not smoked, he has not gone through active exercise just before the sample collection. Everything, all patient preparation is perfect. Now comes the collection. So collection, first, when you, before injecting your needle to the patient's vein, at least twice, you should confirm again the identification. Mr. Shekhar, are you Mr. Shekhar? Okay. Now I'll going to collect one sample from you, as the doctor has requested certain battery of investigation. Why? See, it is the repo, patient's repo is also important. It calms the patient, it eases the patient's anxiety. You just tell him it will a small prick, sir, there will be no much injury, don't worry. A pregnant female coming for a sample collection and a newborn coming for a sample collection and a pediatric patient coming for a collection. So all those things, more the patient is calm and safe, feel easy would be your collection. Verification when relevant. All these requirement, as I told you, most important the drug history in the coagulation test. If the patient is taking warfarin or acetrom, your INR will be, biological reference range is different. So very important to collect the proper clinical history before you start collecting the sample. Then primary sample if you collect, and then it has to be have a secondary, it has an unequivocal link. Whenever, see, once you collect the sample in a plain tube, lot of investigation are done from a plain tube. Serum investigation, all biochemistry investigation, all hormone immunoassay, lot of special chemistry. So you divide your primary sample into the secondary samples. You do aliquoting. You put a different sample in a different hormone immunoassay analyzer, you put in a biochemistry analyzer, you do certain manual thing. So centrifugation. So whatever your primary sample, it should be traceable to your all the parts of the further sampling. Secondary sample, tertiary sample, whatever. So that should be ensured. Any moment, whenever you've been asked that, ये patient का TSH कितना है? What is the TSH of this patient? There is a call from a 5th floor of the hospital. Now, you need not to trace that sample from the primary area. It should be unequivocally, immediately traceable that this lab ID or this patient ID, sample is in hormone immunoassay equipment, through your LIS system, it should be reflect, it's in the process. Sir, 7 minutes will be the time to get the result. So that unequivocal link should be there. There should be continuity of the care. Continuity of the care is the gold standard in NABH. Similarly, it is the same for NABL also. And that is the only way you ensure the patient safety. So whenever the sample collection, proper sample, date, time. See, when you receive, I have seen lot of labs have calculating their turnaround time when they receive the sample in the lab. It's not a correct TAT. Your TAT will start from the moment you collect the sample. So your sample collection in ground floor, and every hourly or every half hourly or every 45 minutes, the guy collect the or transport the sample who are already collected in the ground floor sample collection room, and then you receive in the lab, and the guy who enters the software, a sample receiving time. There will be a traceable sample collection time to that receiving time, because you are answerable to the TAT from the sample collection time, not receiving time. And you are responsible to maintain the integrity of that sample once it is collected in the ground floor in the lab, whatever the cycle of your sample transport. You cannot say that I have received sample at 11:15 AM, sir. It's just 30 minutes. It's in the process. Sir, we will deliver result at our defined TAT and it is 2 hours. No, sample is collected at 10:45 in the ground floor. Your TAT should include that. So you need to suppose to report if the test TAT is 2 hours, then you have to calculate from that moment. So you have to make the chain in a way that your TAT suffices the clinical needs. There are no TAT for certain parameters. You need to understand ABG as early as possible. Once it is done, you need to immediately inform. You need not to say that, sir, our critical report timing is half an hour, so we will report after half an hour. Or you cannot say that, sir, it's still in the process. Half an hour is a pretty good time for ABG. Potassium in the ICU patient, create, ammonia. So these are all the parameters which are a very important clinical decision value parameter. So it has to be taken care from the sample collection. You have to count from there. So as I told you, requirements of separating or dividing the primary sample, that should be assured that the whole ID, unique ID is taken care of. Stabilization of proper storage condition before collected sample delivered to laboratory. What I mentioned, that in ground floor when you collect the sample, the storage condition till you transfer, it should be, and then safe disposable after material. Sample stability is very important. You know, you cannot do a testing of a prothrombin time test after the collection of 4 hours. Everybody knows in laboratory medicine. If you collect the citrate sample for a prothrombin time or a activated partial thromboplastin time, you cannot do processing of that sample after 4 hours, or you cannot release the result of that test after the 4 hours of collection. There will be no use. So all this sample stability you need to understand. There are parameters which are stable for certain period only. So it's not like that we have a turnaround time of this much for a routine parameter, for a critical. You need to understand the intricacy of individual test. Transportation, as I already mentioned, many of them, like when you transfer the ABG sample or when you transfer certain critical sample, there should be ice pack in the transportation box, because the temperature is very much important. You cannot just transfer at the 42-degree temperature in the summer, whole box, the sample is laid there for 45 minutes in the sample collection area at the room temperature, and then you receive in the lab and then you do the analysis. It has an erroneous result. It will compromise the patient's safety. Ensuring the time of collection and the receipt in the laboratory appropriate for the requested examination, as I told you, 4 hours. Maintaining the temperature interval in between the transport. Any specific requirement for the integrity of sample, as I give you examples of ABG, ammonia. Then anyway, if you are not able to maintain the integrity of the sample, then there will be a patient safety is already compromised. And patient has gone from the lab, hospital. He is a OPD patient, coming far from a 45 kilometers. You called him for a repeat collection, but it wasn't possible. What happened now? How will you release your report? You have to consult patient and his clinician with thorough clinical information about all the events happen, inform him, guide him about the risk of that result, make sure that advice is clear cut, that repeat collection or a fresh sample collection is needed. That will give you a competent result, and this is a compromised result, sir, and it will not give you a clinical decision value what you desired for. That message should be clear cut, on documentation should be conveyed. So that is our role as a laboratory medicine. We should introspect at times our own things. We should commit whatever you do, because what is the goal? Goal is patient safety. Whatever we are doing in laboratory medicine to ensure patient safety and patient care. Then you should periodically evaluate your sample transport process also. Are we doing it enough? Are we managing in a proper way, or still there are certain further strengthening is required? So transport system from a ground floor sample collection to lab area is still strengthened or not, that you should periodically evaluate. Because when you grow, your sample work grows. So every 45 minutes needs to be taken care. Then if the sample workload is more, then you need to more frequently transport at a less time. So it's not like that once you have prepared a policy that every 45 minutes. But when you prepare that policy that the sample load in 1 hour is around 40 samples, now it becomes 85 samples in a 1 hour, with 5 phlebotomy chairs, 6-7 phlebotomists collecting samples. So your policy should be evaluated periodically. Now once you have collected a proper quality competent sample, now how can you ensure that you are generating a quality competent result? So that comes the analytical phase. So 3 things in an analytical phase comes: man, machine and material. So all 3 aspects should be covered properly. Who analyze the sample? Your staff. So technical staff, your doctors, technicians, they should be well qualified as per the standard, and they should understand the intricacy of all these analytical process and their interpretation of result and their clinical management. They should aware the biological reference interval of each and every test, and what the patient treatment will going to there once I release such kind of result. So then comes the machine. So all your ultra modern well equipped equipments who are in the process of analysis should be calibrated at least once in a year. They should be taken care for preventive maintenance as per standard NABL. At least once in a year calibration should be done, and preventive maintenance. These 2 things are different. Many labs, what they do, they do the preventive maintenance, and at the time of preventive maintenance the company people will do the calibration, and they have a single report of calibration done, preventive maintenance done on the same visit, and they give. And when we ask the lab staff or a doctor that what kind of preventive maintenance he has done in this equipment, particularly like in hematology analyzer, for a hormone immunoanalyzer or a biochemistry analyzer, not a single technical staff or a doctor doesn't know anything about what has been done to that equipment. They have a very good certificate that preventive maintenance has done, but when we ask what are the parts has been taken care in this maintenance program by the company, They don't know. Fluidics, aspiration probe, pipetting, then hydrodynamic focusing, fluorocytometric analysis. See, every equipment there are very critical certain components which are actually involved in analyzing our analyte. All these critical parts of the equipment should be taken care as a preventive maintenance. Why it is NABH and NABL is sensitive for that? Because we want to prevent the future breakdown, uneven future breakdown of that equipment. Because as the equipment grows, there will be chances of some parts to be get injured during the process of long duration. So what is the purpose of preventive maintenance? To prevent unforeseen or accidental breakdown of the equipment. So if your preventive maintenance has been done properly, you can save your lot of time, energy, money, everything. So that is why it is very critical component, and NABH and NABL both are very much concerned that the calibration and preventive maintenance should be done thoroughly and properly. Many labs, when they do calibration, when we do how they calibrate your equipment. सर इंजीनियर आया था, उसने कैलिब्रेशन किया, हम पूछे कि सर वो पूरा दिन रहा था. He came at 9 AM morning and 4 PM तक वो इक्विपमेंट के साथ ही था. He was there with equipment, कुछ कर रहा था. He was doing whole day, he was doing something with the equipment. He is cleaning certain parts, he has something. सर उसने कैलिब्रेशन किया है अच्छे से. और ये सर देखो सर्टिफिकेट. This is the certificate. What calibrator he has used, what number of calibrator he has used, and how he has compared his calibration data with the performance qualification. That is the crux of calibration. कितना टाइम स्पेंड किया था, क्या क्या पार्ट निकाल के उसको क्लीन किया, raw data. Any calibration of the equipment in your lab should be supported by a raw calibration data. Unless the company person doesn't provide you a raw calibration data, you don't accept the calibration certificate. Calibration certificate is the document which ensure that your all measuring parts of the machine are measuring the analyte properly. So it's not about cleaning, and so most of the company what they do, 2-3 calibrator लेके आएंगे, they do the calibration of your measured parameter and then they give the certificate. For cell counter, at least 10 calibrators should be there. It is there very well written in NABL 112 and standard also. So and then you have to assess what is the process. Once the calibrator has been run, the desired CV percentage what he generate, it actually fall in the CLIA guidelines or not. Like platelet CV is 25%, most allowable. But after the calibration, when he done the calibration with 10 calibrators, if it is fall in that range of acceptable CLIA guidelines, that you need to check. So that is supported by raw clinical data of calibration. He has to provide what is the volume of calibrator, what is the content of the calibrator, what is the acceptable CV range for that particular parameter as per manufacturer's guideline, and then also for our own CLIA guideline. So that is how we have to ensure that their equipments are maintained, and unless the equipment are well calibrated, properly maintenance has been done, it will give a lot of erroneous result. Reagent and consumables, whenever you receive a new lot of shipment or a new lot of reagents, it should be lot verification should be done with the previous lot. Why lot verification is mandatory in NABL and NABH standard? See, any reagent is prepared in the manufacturing plant in their temperature condition, their humidity condition. Then in a bulk, in batches, they are parceled to the distributors in your city. Your distributor, when you order, it will deliver to your hospital. It comes to the hospital store. When you put an indent, then it comes to the lab. So if you see the chain, so you have a date of manufacturing, date of receiving, and then you have a date of opening, entering into the service. So why we need to assure the lot verification? Because when you receive the reagent in your lab, it has been manufactured a 6 months or sometimes 1 year before in the plant, or 3 months before in the plant, in their temperature, in their humidity condition. Then you have to ensure that your coming new lot is equally giving a proper result as compared to the previous lot and the temperature and humidity condition of my lab. So that is very important. So that is why we are concerned about the lot verification. Now IQC, once you release your result, your equipment has given your a test result. How will you ensure that your clinician called you and he said that the patient create is you are saying 5.7 and this patient is walking, OPD patient, he doesn't have any aggressive symptoms. How can you generate such kind of results? How will you ensure your clinician that my result is correct? Through IQC. So we have a program, a standard, a very important 5.6 in previous standard 112 and in NABH also, internal quality control. So internal quality control is very important for your patient safety, your lab safety. And how will you do it? You have to prepare a IQC plan in your lab. You have to define what is the IQC material you are using, and you have to define which frequency you are using. Frequency is important. Why? Like if you are a 24 hours working lab in a hospital, like yours hospital, what is the protocol of IQC plan for hematology in your lab? It should be 2-level control twice a day, 12 hours apart at least. So you cannot run only single level control morning and single level control in the evening, and you can assure that our quality is competent. Particularly you should understand a season like this, a monsoon where dengue cases are viral infection, malaria, chikungunya cases are there, vector borne, where platelets are compromised in a large proportion of patients, then you should intentionally include your low level of control in your IQC plan. That will ensure the quality and boost your confidence on your platelet parameter. So your IQC plan should be in such a way that it should ensure the quality of your result. So you have to define your IQC acceptance and rejection criteria. So what we follow Westgard rules. So accuracy and precision, this is more technical, but I just give you a rough idea what is accuracy and what is precision. So what is this? Your results are coming repeatedly in the same region, but it is away from the mean. So your results are precise, but they are not accurate. Here, this is what we desire to in lab. So your result should be having a reproducibility, and it has to be have a accuracy. So that is how you confirm your laboratory results are accurate, and you are definitely called your clinicians and say your clinician, sir, my 2-level of create controls are accurate and precise. I am sharing you the screenshot of my today's 2-level control with LJ graph, and it is very well near to mean within plus or minus 2 SD, and you can definitely rely on my 5.7 create result, even if it is a OPD patient. You can now investigate the patient with certain other parameters and whatever clinical judgment, but my result is 100% accurate. I have gone through my whole data from patient identification, pre-analytical, analytical and post-analytical. I have taken care of all my 3 segments. So that is how you build your confidence on your own result. Okay, so you also know as a clinician, it may happen then patient come walking with 5.7 create. But clinicians, obviously they need to confirm, and we are there for them. Okay, so should be your goal, precise and accurate. And what is this? No accuracy, no precision. So every such result should be discarded. Control value and design. So you know the particularly those who are working in laboratory medicine. I am not going into detail of much technical, because these are wasteguard rules. We internationally all the standards support this, what to follow. 1-2S, 1-3S, 2-2S, R4, and these are the acceptance of QC criteria, IQC criteria. So this is the one warning rule, 1-2S. When your control result, one of two controls fall outside plus or minus 2 SD, then you should, it's a warning rule. So you should cautious about that parameter. And when that comes 1-3S, result run must be rejected. You cannot release such kind of, if the IQC of any of your parameter in lab falls outside this plus or minus 3 SD, then you should stop releasing the results, whatever been released before that IQC, retest them again and consult your clinician that this has been happened, and we will work on that, and we have to do the IQC again. This 2-2S, this is also if your both two control values are fall outside of plus or minus 2 SD, then also you have to be very cautious, and then patient results should not be reported. External quality assurance program. Everybody knows that laboratory medicine as per NABL and NABH standard has to enroll yourself in proficiency testing program. And why the standard is still worried about external quality assurance program? See, even if your IQC is stringent, then also standard suggests that you have to enroll yourself in the EQAS program. You know, when you receive a reagent, in every reagent, in a create reagent or in a sugar reagent or in any of the biochemistry parameter, it's not only the reagent. What is there? You go today in your lab and read the that reagent composition. It has some water for dilution. It has some chemical substances to preserve that reagent. So that is called matrix of the reagent, and that is prepared in the plant, and when you receive in your lab, it has a different behavior. So that should be, you need to understand that even if your IQCs are stringent, you should always compare your in-house results with certain third party. See, when you assess your own lab, you don't find any NC. When a doctor visit that, चलो मैं आज internal audit करता हूँ एक section का, one section I'll do. So he find everything is good and good. Very little things to put on paper that I done. I internal audit, 2-3 observations are there. But when comes the external party, third party examination is always, we value that. Why? Because we are unbiased. We are a foreign people. We don't have any liaison or association with the institute or hospital. We are here to just uplift the existing quality and make some correction wherever possible as a team. So EQAS is like that only. So when you do a proficiency testing program, like in hematology, we take part in AIMS EQAS control, prothrombin and PT and APTT, we are enrolling ourselves for CMC EQAS. For histopathology, there is a Tata EQAS is available, Anand Lab EQAS available. So we enroll ourselves, our lab for a, so they gave samples, we run them, we compare with our result with their result, and then we are falling in the same what you call control limits or not, that we assess. So that is how we gain confidence on our lab that in AIMS EQAS program, our lab standards, we are following AIMS EQAS and we are into the limits. So that gains confidence on your own results, that we are not only doing IQC, we are doing third party control also. So you have to, and when there is a no available EQAS, like I'll give you a simple example. Why this is important, this slide is important. Like I'll give you the example, urine. There is no ECAS program available for urine routine micro. Certain parameters like ascitic fluid, pleural fluid. So how will you ensure that whatever the result for these parameters you generate are quality competent? Because you are doing IQC, but no ECAS is available. So in that, when there is no ECAS available, these are the options. You need to understand that you can do any ILC, inter-lab comparison with the same NABL accredited lab in the vicinity. You send your sample to there, and then compare your result with their result. That is called inter-lab comparison. And then you gain confidence when there is ECAS is not available for certain parameter. So that is the way out, where then you do multiple other things. This is more technical. You do the clinical correlation, interpathology correlation, retesting, blend testing. So this is how you generate the confidence. And post-analytical phase, now the last phase, where once you generate a quality competent result in your lab with proper pre-analytical and analytical portion, that comes the post-analytical, where the results are ready to release. Then how will you release the result? That is also very important, that your report format, its biological interval, proper clinical interpretation with needed comments and advice. So that is post-analytical phase. So this is three portions you need to, three factors you need to understand while before releasing your result. So it should be released by the authorized personnel first. So first there will become the technical validation, then there is a pathologist or a doctor validation, and then comes, it should be checked against the IQC. You have to check that if the patient has a 2.1 potassium, so then I immediately need to check that my potassium control of today is okay or not. Then it should be matched with the clinical information of the patient or not, and then previous examination result of same patient. If the potassium come in the morning and it comes again in the afternoon or evening, you should also check that this patient is on dialysis and doctor is titrating the dose of the medicine to finalize the dose today, and that's why he's sending multiple time potassium of the same patient at different intervals. So you should check that also. So these are the very important factors before releasing the result. It should be first released by the authorized person. It should be checked with the QC of that date. It should be matched. It should be considered with the clinical information, and it should be considered with the previous examination result. So that is the most important. And why this is important? To generate the most important factor in the hospital and healthcare, that is patient safety. So your patient safety should not be compromised in any of these phases. Critical, as everybody knows, critical results once generated immediately need to be informed, and how you inform, that is the most important part. Critical result raat ko 2 baje, night 2 AM, when a ICU patient has a potassium of 1.9 or 2.3 and it falls in your critical, and how you inform, that is most important part. You record your critical results in your register or in a soft copy, that is okay, but how you inform? So that is the most critical part. How you inform? So the person who is informing the report, it should be noted. Whom to inform? A concerned person over there who is able to convey the message to the doctor to take the decision of that particular patient. Then redo. Ask the patient, Mr. Sekhar has 2.3 potassium, whatever on the other side, whoever so. So then medical officer, you need to confirm, and then ask him to repeat the same sentence to him. Sir, I inform you Mr. Sekhar's potassium and it is 1.9. Can you repeat it what I inform you? Because at night 2 AM, he may be drowsy. And that morning, he is told that, sir, मेरे को किसी ने बताया नहीं. He will tell the consultant that, sir, 1.9 तो ऐसा तो कोई आया ही नहीं था night में. So what is the evidence you have? So you have to first note down whom to inform, when to inform, then Who is the other person? Medical officer or nursing staff, name, time, date, everything. And then repeat again. So that he should also aware that, oh, this is 1.9. I need to do something. At least I need to work on this patient, or at least if I am not able to do it, I have to inform my consultant. So that is very tricky in particularly hospital setups. And if you call 10 times and there will be no phone contacted in the ICU, what happened? Then you have a definite escalation procedure. This is the standard requirement. These all are from a current 2022 standard. Okay. So you need to understand that there should be escalation procedure, where if the contact is not possible, you have access to all those medical officer and consultant doctors number, and you can directly call them, inform them, and write down in the case paper that we have informed. Special consideration, as I told you, certain government authorities require certain data from lab in the hospital, particularly set up where IDSP, vector-borne disease program, malaria control program. So when the patient is there in the hospital, you should convey that patient that certain of your clinical data, patient reports are to be, we need to convey to the regulatory bodies. So that has to be conveyed also. They should understand why my result you are informing some third party. Why you are giving my results to some other authority which is not in this hospital. So you need to understand that intricacy also. Particularly certain genetic report and certain reports like serology tests like HIV, before releasing result, you have to counsel the patient, post-counseling properly done. Now last few slides where we need to identify the risk in the laboratory medicine for patient safety, and risk management is very important, and the NABL 2022 standard is focused on risk emphasis. So you need to identify which are the risk prone area in lab, like in sample collection area, needle stick injury, spillage. They are the wrong identification in terms of patient safety. Okay, wrong entry, number of tests missed. So clinical result displayed without IQC check, machine is not calibrated, preventive maintenance has failed. So all those risk area in terms of equipment, in terms of manpower, in terms of process, in terms of procedure needs to be emphasized for the patient safety. So all these are to strengthen our management, and all this to be mitigate towards the patient care. Incident, any incident happened if there is a typo error and result is released. So you should open up like in laboratory medicine, it has a lot of drastic effect. Create 1.23 and that decimal goes to 12.3, shift of 1 decimal. Think how difference it will make, a typo error. In current era, we have a lot of data directly transmit from machine. So we don't have such kind of error now in our setup with the help of LIS. But standard will take care of everything, starting from a small lab. So we need to understand all those incident, all these happen in lab, like in mistake in name, like third party comes to you with the reports that my name is not correct, or same name patient in the ward. How can I assure it's my report? Then you have to have a proper procedure that you need to say that we have a lab unique ID, MRD number. Even if you are a Thomas Joseph, there are 2 Thomas Joseph in the ward. But see, sir, your admission is time is this, your MRD number is this, our lab ID is this, your unique. So all those, and if any incident happen, then you have to open up to safeguard your patient, to say patient safety. You have to convey that that incident has happened and because of this, and they have you have to have a record, because then only you can analyze at the end of year that how come we decrease such kind of incident. So downtime plans, whenever your systems are failed, lab has a lot of automation in laboratory medicine. If your software get hang, you have a contingency plan that you should release at least critical result report with the manual format or some other options. Word, Microsoft Word में type करके दे दिया. So you need to understand that your patient care and patient safety should not be compromised in any event of failure. Okay, all your data of lab data should be backup in a hard drive, and it should be stored somewhere else, not in the same institute. Why? If something natural disaster, let's say, happened, like in terms of fire or in terms of flood, earthquake, then your whole data, if in the same institute, it will, so it is advisable to store all those data in a distant place where it is being taken care of the privacy and everything. So this is the last slide where I taken all these patient safety pre-analytical, analytical and post-analytical phases as per our current 2022 standard only. Okay, so there is no separate need for because I convey all those safety measures in terms of current standard only. Okay, so and what is new? These three things are new in our 2022. So alignment is management requirement is now at the end of the document, and it is aligned with the ISO IEC 17025 requirements of POCT, point of care testing. You know that glucometer at the bedside, we do RBS by glucometer. Nowadays, in near future, there will be lot of point of care testing devices are coming in the market. Bilirubin, Propi, you know the portable ABG, cartridge based ABG at the, yeah, lot of point of care devices are coming up in the market. So NABL current new standard involve all those point of care testing devices in the current standard, and it is the responsibility of the lab to take care of all those phases of laboratory medicine to be taken care in such devices also, and increase emphasis on risk management. These are the three changes, and these are the alignment. Risk management is aligned with principles of ISO 22367. Laboratory safety are aligned with principles of ISO 15190. Sample collection and transport with ISO 20658, and point of care testing device surpasses, and this is aligned now, and the whole format of current standard is based on 17025 2017. So this is the changes, and if you see the current standard and read the new standard of 112 this NABL 15189 2022 version, it is patient centric. So the purpose of today's conclave, patient safety, is the most important. 80% standard is focusing right now on patient safety. So see, the QCI and bodies like NABH and NABL is same in alignment with the where world is going on. All the international standard, and we are happy as a part of a laboratory or a healthcare team that we are keeping up pace with the all international standard, because all international standards in healthcare are focusing on patient safety, and now NABL and NABH is also, they are there since years on patient safety, but they are evolving in terms of patient safety continuously, and this current standard reflecting again and again that only. So I conclude my talk with this quote. I like this quote very much as a quality assessor. When I do NABL and NABH and NQAS assessor, as an assessor, do my part of assessment, I always feel that this is the most appropriate for the quality. See, quality is generally transparent when it is present, and it will easily recognize in its absence. So when you visit a hospital or a lab for an assessment, by just doing a round of 15-20 minutes, you just open your eyes and just listen to the environment and just go through a half an hour in the hospital. You'll come to know a lot of things. And Dr. B.K. Rana sir is our faculty when I trained myself for NABH Standard. And I always learn from different platforms from him also. So he must be agree with this. So we come to know many things, even if when we don't interact, we just by observing. So quality is always there. It will come out when it is there as it's present, and it is easily recognized when it is absent. So which is there, and it's a everlasting journey. It's a continual process. It never stops. You learn daily, you evolve daily, and quality is such a kind of subject. We also learn daily. We also, as during assessment, learn many things. So I conclude my talk with this. So thank you very much for the patient hearing, and I'll happy to interact in the break for any of the questions and any of the doubts of my talk. Thank you very much.
Ladies and gentlemen, the floor is now open for questions. So please feel free to ask any questions you have.
Any questions?
I can take few, if any, right now.
Sir, actually, when we are discussing about the TAT, you are saying that actually because of the TAT, we have to calculate from the time of collection onwards. I do agree with that, but sir, in certain laboratories where we take B2B samples, like samples comes from outstation. So I feel it is a bit difficult to calculate because how do we tackle with those kind of things?
So when you collect the samples from a B2B, different labs,
yeah.
So that doesn't mean that PT should be not monitored, analyzed within 4 hours. Why PT should be analyzed within 4 hours? Because the test analyte has its own limitation. After 4 hours of collection, prothrombin time will not give us an accurate result in a whatever the best equipment in the world and whatever the best reagent you used. So you need to understand that once you receive a sample from a distant lab or a different area which is far, it doesn't mean that you allow that error to happen to the patient. So big no, you should calculate your TAT even if you receive from a distant lab. You emphasize all the collection centers or a distant lab that you should write actual collection time on the sample and the person who has collected the name and signature also and mobile number. Why? Because at times you need to confirm with that guy that actual time was this or not. Because what happened, a distant center maybe sometimes give a wrong collection time because he knows that I want anyhow the result of this test because otherwise doctor will not happy with me. So he may modify the lab person when they send to the sample to you, he may modify it, but you should, it's your responsibility because patients, see, when I am not doing any test in my lab, I'll refer that test to the referral laboratory. There is a separate clause for referral laboratories in standard. So a patient come to me and then he said that, sir, you said that your torch profile report will come in the evening only after 8 hours. I came, but your staff is saying that you have outsourced to the different lab and it will take time and it will reach it will take further 4 hours or tomorrow morning. Then you are breaching the standard because it is your responsibility to convey the actual TAT to your patient when you receive the request. That is called service agreement. When you receive the request to the patient from the patient or the consultant, that is a service agreement. Standard said it's the agreement, like a loyal thing. Okay. So you are liable to any delay or any quality compromise of the sample which you have not even processed. You cannot say the patient कि sir मैंने तो I have sent it to the referral lab, उन्होंने delay किया तो मैं क्या करूँ? I am not nothing to do with that because they have done the delay. Then it's your response because patient knows you. He has made agreement with you, not with that referral lab. And that is why referral lab TAT monitoring is also a standard in NABL. That how frequently you visit the referral lab, how frequently you check the IQC of that referral lab, how frequently you check that they are processing. See, you send the torch profile to referral lab and that torch test is not in the NABL scope of that lab. So what is the fun of sending that torch profile to the referral lab who is not NABL accredited for that particular scope? So that is a big NC, major NC, because see, I am responsible to the patient who comes to me. Once the patient or doctor give a service agreement or a request to me, I am the 100% responsible of the result of that test, even if I am not doing in my lab and I am just giving that. You have to ensure the patient that your scope should be also displayed and conveyed to the patient that these are the tests we are doing in-house and these are the 6, 7 or 9 or 10 tests we are outsourcing. So you are not saying that it is outsourced, so we are not responsible for the TAT for that. So then you have to every 3 monthly check also. In standard says that the TAT of referral lab, and then you have to, whatever the labs who are not following proper TAT, you have to stop sending samples to them and identify the different options.
No sir, actually rather than the referral test, the sample we collect from outside, suppose some
even if I understand,
which actually send samples to us, because I'm not emphasizing on the point that actually because PTANR, see for quality purpose we can stop taking PTANR or even electrolytes. We will not take it from outside. No, we are an NABL accredited laboratory, we are not going for that. But other parameters like thyroid or even any other markers actually which comes to our laboratory, and generally we process it. But what happens is actually because our internal TAT would be better, but when the B2B sample comes, our TAT got messed up.
No. Actually, it is our responsibility only. Whatever the test, even if the hormone, immunoassay, electrolyte, whatever the test you receive from different centers, see, starting from that, and you have to check the pre-analytical portion very importantly, because all those samples coming from a different region or a distant region, maximum pre-analytical errors in that.
True.
Because you can see, you control whatever done in your premises. You cannot control whatever done in some other premises which is 50 km or 30 km away, and the different kind of staff where you are not regularly interacting, you are not understanding their competency, you are not knowing their quality of processes. So that is the most gray area. We should avoid such kind of thing. We should always see, I am not saying that you should not doing testing of or distant centers. You can do, and everybody in all the big labs, they are receiving sample from far region from the country. They are doing, but you should ensure all these phases should be taken care. Sample collection, quality of sample, quantity of sample. Sometimes they collect the sample of a low quantity. They said that battery of investigation was very large, so we have remains only this much sample. Sir, you process it, whatever the result, we are responsible. That's not done, because ultimately you are doing the analysis. That lab will ultimately tell you that this result is not done by us. It is done by, when there is a court of law, they will catch you up, because you have done the analysis and you have given the report of on your letterhead with your signature. Okay, so that's. Thank you very much.
Thank you, sir.
Thank you.
Any more questions?
Bhaskar, can I add something?
Yeah.
Thanks.
Yeah.
Thank you, Prashant, for good question, a good explanation. But I think it's not that, it is very complex. It depends on many factors, including how you define your TAT, who controls what, how you explain and communicate to your patient or clinicians. There are 3 factors involved. You define TAT for some test which does not suit you from your point of collecting sample and bringing to the lab for testing. So what you control is under your control. You can't take control of something which is collected 3 hours away, and you define a time of 1 hour for a round. You will not receive the samples. So what you control is important. Second thing is, one requirement is called sample acceptance and rejection criteria. So if you define a TAT of 4 hours, because as per what he mentioned is the test to be done within this time, because otherwise the analyte quality will change. So you cannot define TAT beyond, number one. Number two, you can't accept a sample which is collected 4 hours prior to your receiving for testing and say this is my TAT. That's totally wrong, because you should not accept that sample. Because even you test within your own TAT defined, from the point you receive it, you are not going to do justice with the sample, because the results will be totally wrong. So I think it's not easy. I think we all need to understand it. And more importantly, we have to communicate it to the patients and those collection centers which are sending sample to you, or the labs, which is entirely missing in my opinion. People just say, this is my TAT, I get it, test it, and give it to, go to hell. I don't care about you, because sample was not actually to be tested, which I tested and give the results for. So I think it's very complex, and we have to really very clearly define and most importantly communicate to the users. Thank you.
The standard has also put emphasis on the same sir has said.
Yeah.
So what I have conveyed.
Sir, good morning, sir.
Yeah, good morning.
Sir, now I heard both of you. There was one query from my side, because nowadays there is a disclaimer coming down in most of the laboratory reports saying test result reported is the sample received in the lab. Is it correct?
What is the disclaimer? Can you speak bit
The
loud?
disclaimer come as results reported are to the sample received in the laboratory. Means B2B sample, as Dr. B.K. Rana told now. So we don't have the control on that samples. So giving a result with disclaimer, is it fine?
No, you cannot save your skin with just such kind of disclaimer. You are just informing your consultant that these results are, see, once you receive sample in your lab, you are bound to give the quality result. See, if it is not in your control, the collection part and pre-analytical part, then you have to ensure those who are sending sample to you that they should take care of those critical component. Because I told you in the very first slide that 70 to 85% errors in a most ultra modern labs in this world occurs in pre-analytical phase.
Sir, this disclaimer is even given in many NABL accredited labs also.
No, I am not against this disclaimer. I am saying that that disclaimer doesn't give you a guarantee to give you a compromise result. Disclaimer you can write, but you should emphasize in court of law. You cannot save your skin that we have just write a disclaimer and we are not responsible for that. No, you can write.
Was correct.
No, that is, you can write, but whenever there is a dispute in the quality of the result, and when you have been asked, or that third party lab has been asked, and that lab say that we have not done the analysis, we have sent to this lab and this lab has given the result. And when you've been asked, that you cannot just say that, sir, we have not collected sample, we have done the analysis, whatever been given to us. It is your also duty to ensure the quality of the collection, and all those pre-analytical identification should be taken care by the, because you have some agreement with all those. So that is how you have to work for a patient safety in a goal where we are here for towards achieving a more and more quality competent lab result, which is the mainstay of clinical management in current era.
Okay, sir.
Just one thing. Again, I'm saying we need to understand disclaimer is totally different than what is to be done. It's like if you get a product for eating and it says store below 25 degrees centigrade, there's a disclaimer sort of thing, the condition. But does not say that you should not use it if you go up or go down, right? It's up to you, that how you use it appropriately. So disclaimer will say that yes, I tested what I received. But before that, you give this report, you have to show whether you can test this sample or not. It should fall into your rejection criteria, and this report should not even come to the patient with this disclaimer. So disclaimer is totally different what you actually do.
Any more questions from the audience?
Hi, sir. Sir, if I have two methods for one parameter, so which tool is best to measure the assay variability? Is it Carl Pearson or Gaussian?
See, for sure, because see, whatever method comparison, you mean to say the verification of the method.
Yes.
So we do interchangeably method, use of method. I'll give you a simple example for this. Like I am doing creatinine on my fully auto system. A create parameter I am doing regularly on my fully automated system. Suddenly the breakdown comes in the afternoon, and the equipment engineer came and he tell me that, sir, it will take at least 2 hours, and there are 3 samples coming from the ICU. Okay, so I have a semi-automated equipment as a backup instrument in my lab. See, whatever scope of test you applied for accreditation in NABL, if you have a backup instrument or a backup method for any of the parameter, you should include in that scope. Why? Why I'm telling you? Because when you change your methodology, like in these circumstances, we have to generate the result, we have to give a quality competent result in such scenario, even if there is an instrument breakdown. It is our preparedness should be there, that I explained in the slide. So when you do in semi-auto equipment, your create, and that method is different from that fully auto method. Yes. But you have to have a comparative method analysis document in your lab, that whenever such situation happen, my variability of the result of this parameter with these two methods within an acceptable range. It happens, na? See, I am also a pathologist, I am working full day in my lab. So instrument breakdown is not in our control. It can happen, technology can go away. So in that scenario, whatever the methodology you have as a backup instrument or a second method, you should have a compatibility with, as you mentioned, you can choose either of them, but you have to mention in your plan, in your IQC plan or in your backup plan, that these are the analyte we do with different 2 methods, and we have a method comparison of both these methodology, and we have checked the CV percentage, and it is not beyond our rejection rule. It is in the acceptable criteria.
Okay.
Yeah.
So if it is same method, then there is no need of to apply such tools.
No, no. If it is same method, there is. If the instrument is, there is another scenario. Instrument breakdown is there. Method is same, but the equipment is different. Reagent का जो methodology है, create, if it is same, instrument is different, then your equipment, the other backup equipment should be well calibrated, and well preventive maintenance of that equipment should be done. So inter-instrument compatibility, that is also, you have to have a document. Whenever there is emergency situation, you can have this document, and you can use that analyte on different instrument and give the result if it is falls in the IQC limits.
Okay. Thank you, sir.